Assalamu alaikum. Good evening, everybody, and welcome to this joint webinar between the Emirates Diabetes Endocrine Society and the Diabetes India. In this webinar, we have 4 speakers, 4 topics to cover, and it will be recorded and available online as well. My name is Jumal Kabi. I am the Vice President of the Emirates Diabetes Endocrine Society. It is my pleasure on behalf of the society to have a joint meeting with the Diabetes India Society. And this webinar will be recorded on YouTube, belong to the society and at the society website as well. It is CME accredited, so please write your name as you like it to be appearing in the CME certificate, and you're going to receive the CME certificate within 14 days from this webinar. It is CME accredited by Dubai Health Authority, and our session will start with 4 talks and ending with Q&A sessions. If you have any questions, please key in your questions, and we're going to respond to it. I'm co-sharing, I'm moderating this event with Dr. Banchi Sabu. He's a founder and chairman of the Diabetes Care Hormone and Clinic, which established in 1998. He's a PhD scholar at Gujarat University, principal investigator in multiple clinical trials. He's the chair-elect for the IDF Southeast Asia and the past president, secretary of Diabetes India. He authored over 470 publications, and he's the editor-in-chief for a number of international journals. He is the president of the Di India Trust and managing trustee on juvenile diabetes. It's our pleasure to have Dr. Banchi from the Diabetes India, and he's going to cover a talk as well, and he's going to present. It has been a short notice, actually. He's covering for Dr. Amit Gupta on a short notice, and thank you so much, Dr. Banchi. And the title of the talk will be Emerging Frontiers in Diabetes Therapy. What is in the horizon? The floor is yours.
Thank you, Dr. Juma, for kind words of introduction. There are few sentences were not correct. I am not chair-elect. I am currently chair of International Diabetic Federation from Southeast Asia. Not having 470, it's 300 plus some publications. and thanking and acknowledging the presence of Dr. Arvind and Dr. Amit. Arvind is our currently President of Diabetes India, and Dr. Amit is the Joint Secretary, as he has to attend a Asia Pacific meeting in Vietnam. So he's on the way to airport, and that's what I'm going to present his presentation. I'm thanking Emirate Diabetic Society. Actually, I have written Emirate Diabetic Endocrine Society that we want to co-host a meeting, and Fatia and you agreed for it, and I'm really very thanking you for that. I'm thankful for that. And we are doing a lot of activities with many neighboring countries association, along with some of the international association also, to do webinars in this World Diabetes Day Awareness Month. As today is Eve of World Diabetes Day, our expectations were there that we will have more than 2,000, but still we have more than 800, 900 delegates who joined live. And I'm very happy that more than 400 are from Dubai or from UAE. What I'm going to talk in next 20 minutes, the slides which is shared by Dr. Amit Gupta. My slides are visible?
Not, yeah, now it's coming up. Just need
Yes.
enlargement.
Yes, I'm doing it.
Enable editing. And
Yes,
then-
is it fine?
not yet, no.
No?
Yes, no, yeah, now it's good.
Okay, okay. So just to introduce my close friend and joint secretary from Diabetes India, and he's practicing at Noida, which is National Capital Region, Delhi. He is currently joint secretary of Diabetes India and chair of International Diabetic Federation School of Diabetes, with multiple things which he is doing. But he's also executive editor for our Sadiko textbook of diabetes, and involved and very active person in field of diabetes from India. What he has given the slides, I am not changing anything. It's from, he is talking on emerging frontiers in diabetes therapy. That's what I'm going to talk in next 20 minutes. We all know about this slide. International Diabetic Federation data is talking that in 2024, IDF Atlas is talking that 1 in 9 adults has diabetes. That's what 589 million people around the world are with diabetes, and 3.4 million deaths are due to diabetes. That is what the latest statistics in IDF Diabetes Atlas. But number of people with diabetes are increasing all over the world. Whether you see Southeast Asia, or you see the Middle East, or you see any part of the world. But we are Southeast Asian particularly, or Indians, which we have typically thin fat Indians. We have higher visceral fat. We are developing diabetes almost 1.5 decades earlier. And we have high insulin resistance, and we also develop more cardiovascular disease too. Globally, many people with type 2 diabetes, just a minute, I think so. Yes. Many people with type 2 diabetes do not achieve glycemic control, and that's true all over the world. It's not that only India and some parts of the world, only 2/3 of diabetic patients are not under good control, but many of them around the world are not having good or tight glycemic control, maybe for many reasons which they have. And one of the important reasons for them is to have is the excess weight or insulin resistance. That's a reason for them not to achieve a tight glycemic control or regular monitoring, non-compliant, and clinical inertia. What decision cycle for a person? Because a person-centered approach is that's what the approach should be. So first is assess the key person characteristic, consider very specific factor that impact choice of treatment, utilize shared decision, whatever the treatment which we are planning with the patient, we have to share the decision and then agree on a management plan. This is what in a clinical care with a person with diabetes we try to have. And then whatever we have agreed on management plan, we implement that, and then there has to be an ongoing support program and a regular monitoring, and then we have to review on whatever the management plan for which we agreed, and we try to find out whether he's achieving tight control or not. This is what ADA ESD guideline is talking about. Here is not just the sugar control is important. It's not the glucocentric approach will work. Our primary purpose of treatment is, other than glucocentric approach, is to prevent the complication. And primarily, we are preventing the complication from cardiorenal. That's cardiorenal protection. the medicine which we are going to use, they should also have uh, uh, the way their mechanism should be like that. They should protect the cardiorenal and the data should be like that. But along with that, we also want weight management. Plus, we have to give therapy which is going to take care of multiple cardiovascular risk factor which a person is having, because a person with type 2 diabetes, 70% of the time, they are going to have the cardiovascular disease. And weight reduction is a very targeted intervention. Weight reduction is seen as a strategy to improve glycemic management and reduce the risk for weight-related complications. A weight loss of around 5 to 15% is a primary target in management of many people living with type 2 diabetes, typically a obesity. And even with 5% reduction, there are a lot of metabolic risk factor get reversed, but up to 15%, a lot of things get really getting reversed and complications of obesity also. A higher magnitude of weight loss confers better outcomes, as we know that 5 to 10% will give you good metabolic improvement, but 10 to 15% will give you even a disease modifying effect also. So weight loss may exert benefit that extend even beyond glycemic management, just not the good or tight glycemic control, even beyond glycemic management will get the benefit too. In a 5% management, as I told you, 5% weight loss will give you the benefit for glucose control, for 5 to 10%, for dyslipidemia, for hypertension, for MSLD, even for preventing type 2 diabetes. Somebody is already pre-diabetes, for 10 to 15%, even like knee osteoarthritis or some of the mechanical problem of obesity like OSA and GRD benefits, even menstrual or urinary stress incontinence, and some benefit for cardiovascular disease too. But more than 15%, we get real benefit of even decreasing CV mortality. Type 2 diabetes get remission, as well as with person with preserved ejection fraction, also there are benefits. Different medications which are there to lower hyperglycemia in type 2 diabetes. But now the first choice of therapy with a person with type 2 diabetes, we have to see whether they have established cardiovascular disease or not, whether they have heart failure or preserved ejection fraction heart failure, whether they have renal failure or not. So these are the important comorbidities. Other than that, weight is also very important. RSSDI, our own guideline, had come out with a after A1C, it is BMI status of CKD and established cardiovascular disease is also very, very important when you are dealing with type 2 diabetes patients. Now, the agents which have very high efficacy, not only for glucose control, but we also have very high efficacious drug for weight loss too, which is including semaglutide as well as tirzepatide. And they are the one who are not only going to have very good glycemic control, the significant amount of A1C getting reduction by these newer GLP-1 analog or GLP-GIP, but also they have benefit for weight loss significantly. And now we have the cardiovascular outcome trial also to show that they are the choice of therapy with the persons with established cardiovascular disease too. What are the advantages of these novel treatments for glycemic control, which are also helping us to decrease weight? They have targeting multiple mechanisms. We know that type 2 diabetes or hyperglycemia in type 2 diabetes is a multiple pathophysiological factors which are responsible. And these multiple pathophysiological factors are targeted by using these GLP-1 and GIP combination. They are also potential to improve tolerability, potential effect of novel molecules on body composition. There are even oral administrations are also available because oral of these molecules are also outcome data. They drive clinical guidelines recommendation too. So the tirzepatide and the molecule semaglutide, which we talk, the dulaglutide, which is also available in India and many parts of the world, even liraglutide once in a day, that is also available with established cardiovascular disease. So these are some of the GLP-1 which are available. But in future, along with GLP-1, we are going to have the cagrilintide, which is a long-acting amylin. It is co-secreted with insulin, amylin from beta cells in pancreas. It is stimulated by nutrients and glucose. It controls satiety by acting on amylin-sensitive brain area. So we were having GLP-1 agonist, now GLP and GIP, which is tirzepatide, but in near future, now phase 3 trial is already going on. We are going to have cagri-sema combination also, which will be a long-acting amylin analog along with GLP analog. That is, the trial is redefined, which is been published recently. It's a phase 3 randomized double-blind placebo and active control, a multi-center trial where Kegri-Sema in combination, individually also Kegri and Sema 2.2.4 and placebo. So they were randomized in this proportion. The endpoints was relative change in body weight and proportion of participants who are achieving more than 5% weight reduction with safety. While inclusion criteria were all adult patients with BMI of more than 30 or with more than 27 with one obesity-related complications. The redefined first efficacy results change in body weight. We'll see that significant amount of weight reduction was there with a mean baseline weight of 106.9. And it was with Kegri-Sema combination had reduced 22.7. That was what is the combination of amino analog with GLP. So this is what a molecule which is going to be there in near future. The people with placebo, it was 2.3. Individually, Kegri could reduce around 11.8. 16.1% weight reduction was with semaglutide. And with Kegri and Sema, the combination had reduced almost 22.7. It has also shown that more than 5% weight reduction was almost 100%. So that is what everyone was reducing the weight. We know that patients with semaglutide with 2.4, it is almost 89.6. So that what we say that 90% of them are reducing the weight all more than 5%. With Kegri was reducing almost for 81.4%. With a more than 10% weight reduction was found in 90%. The percentage weight loss was there with more than 15%, that was with 78.3. 60% of the patients were reducing weight by 20%, and 25% of them were reducing by more than 40% of the 40.4. And more than 30% weight reduction, that's very, very significant. There is 23.1, almost you can say it's like a bariatric surgery, medical bariatric surgery with a reduction of more than 30% weight reduction was there in the 3% patients. So the completely shift in BMI category, those were the patients who were weight of obesity class 30.2. You can see they have reduced to significant in combination with the Kegri-Sema, very significantly the weight reduction. So they completely shifted from the class, from the BMI category also. The redefined 2, it is again phase 3, a randomized double-blind placebo-controlled multicenter trial, which is a male-female patient, adult patient with his type 2 diabetic patient with 7 to 10% HbA1c. Again, a combination of Kegri-Sema was used against placebo. The primary endpoint was relative change in body weight and proportion of patient who were achieving more than 5% body weight reduction with safety level. And here, the patients who were diabetes. And here you can see the weight reduction was around 15.7%. That was change in body weight from baseline. With a mean base of 2.2 kg, this is what the weight reduction. Again, nearly 9 out of 10 diabetic patients were reducing more than 5% of weight loss. And again, more than 10%, it was 74%, more than 15%, it was 51.6, and more than 20% were almost 1/3 of them were reducing more than 20% weight reduction was there in the diabetic patients. The HbA1c, as I told you, these are the molecules which are significantly reduce the glucose. The A1C reduction was 2.1. That's a very, very significant, and that you can say within 20 weeks, there was a significant HbA1c reduction in a patients who were on a combination of Kegri and Sema compared to patients who were in the placebo control. The efficacy less than 7, 89.6% of patients could achieve, and less than 6.5, it was in 81%. That's about the significant HbA1c reduction was there. Proportion of participants who were achieving less than 7 and less than 6.5. That is what the target A1C, which you are redefined 1 and redefined 2 efficacy results in not only in just glucose control, but improvement in cardiological glycemic parameters too. That is the reducing systolic blood pressure, reducing the lipid level, reducing high sensitive CRP, and improving glycemic stability and lower hypoglycemia. That no hypoglycemia, no glycemic variability, all these were there. What is the most common adverse events with redefined 1 and 2? Definitely GI symptoms were the more common, nausea, vomiting, constipation. There were adverse events which are there, but discontinuation was very uncommon and treatment was reasonably well tolerated. Then the new molecule had come. This has also been clinically tried because of a lot of issues were coming with the persons who were losing the weight. There was also significant muscle mass they were losing. There was a fat loss, but there was a muscle mass loss also there. This is one molecule which is bimagrumab, which blocks activin signaling to increase muscle mass and decreasing fat. This particular molecule was found to have very effective inhibiting muscle that effects of activity signaling on muscle and adipose tissue, that one side it decrease the fat muscle mass but increasing the muscle mass, and it acts independent of CNS appetite or satiety level. They have done the study with this particular molecule is believe study. That is, study design was again placebo, BIMA 10 versus BIMA 30. Again, it was compared with semaglutide 2.4, and then they had a combination of BIMA with semaglutide also in 10, 30, 10 plus 2.4 and 30 plus 2.4. So this was a design study. Particularly, it was open label first. Extension was done, and then there was again for 8 weeks there was an ongoing treatment was stopped. Believe study had shown the weight reduction with a combination is almost 20.2% weight reduction was there. A patient from percentage change in body weight from baseline. When it was independent only using semaglutide, it was 14.2, and when alone BIMA was used even in 30, it was only 9.7. So in combination, it has got a very significant weight loss. But what more important is body's lean body muscle mass. That is increased by 2.3 in the patients who were using BIMA. And the patients who were using only semaglutide, there was a decrease in 7.9% change in total body mass. So you can see the patients who were used bimavimab, they were actually increasing lean body weight also. The summary of this efficacy, there was a body weight reduction and there was a lean muscle mass. The patients who were in bimavimab with 30 milligram per kg, there was an increase in muscle mass also in compared to the patients who were using only sema. But in combination, there was at the end, it was showing some decrease in lean muscle mass also, that was by 2.9. But weight loss was primarily more with the fat muscle mass loss, not with more of muscle mass loss when bimagrumab was used for this patient. But there was no very significant adverse event which was there. But yes, again, all GI symptoms and GI side effects was there: vomiting, nausea, constipation, diarrhea, and some of patients with the diarrhea was very high to stop the medication also. The new molecules which had come is a caphraglutide, a dual target peptide, which is a monoclonal antibody backbone, which is GIP receptor antagonist and GLP-1 analog peptides. This is a molecule which is a conjugated peptide, which is a monoclonal anti-GIP antibody and GLP-1 RA peptides. They can be used in a not once in a week. They are like monthly or bi-monthly dosing. That's something which is very long high flying. Still the phase 2 trial. It is not even yet come in phase 3 trial, but this is what the future is. So a lot of GLP-1 and GIP and the different combination which are going to be there. We don't know that how many of them will be in market, but there will be many in near future. We will be having different combination available to us. This is a randomized double-blind dose ranging trial with meritide versus placebo. This is caphraglutide phase 2 trial. These patients were with type 2 diabetes and without type 2 diabetes. And this molecule was given once in a month. And even if 420 milligram without type 2 diabetic patients, they were given even an alternate month also. And then dose escalation therapy was done starting with once in a month to once in 2 months. The percentage body weight change was almost up to the range of 20% with this caphraglutide molecule also. And HbA1c reduction was also very significant, along with weight reduction, which was almost 17%, with A1C reduction of 2.2. So again, a very strong anti-hyperglycemic agent without getting any hypoglycemia, along with other cardiometabolic parameters because of its significant weight loss was there. So obesity and diabetes care, it become a very very center point whenever we are treating a person with diabetes. The obesity management has become very, very important part. Now you can see that any association in the world or any organization of diabetes in the world, even in their annual meeting, you will find 30-40% of the things are around obesity, or even in their exhibition or for any scientific meeting, all the scientific talks related to obesity had become the primary focus, because managing obesity or treating obesity means preventing diabetes or reversing diabetes, or decreasing the risk of cardiovascular disease in a person with diabetes is very significant. The tolerability will be a focus for future trials. So what the different newer molecules, they might be reducing the weight reduction between 15 to 25% or 20%, but the tolerability is the most important. So more the tolerable, better is that molecule is there, but along with definitely cardiovascular risk factor also should be reduced. The flexible design may improve adherence, as I had shown you the some of the molecules which are coming even once a month for that. 15 to 20% weight loss is really enough for substantial health benefits which we have. So targeting a healthy weight loss without decreasing the muscle mass, that is what scientists and all the newer molecules are looking for, that we want to decrease more of a fat, not of muscle mass. That's a very significant important part of it. Remember, obesity is very heterogeneous disease. Even response to medication will vary, and individual response from medication will also vary. We have seen that some patient is losing only 5% or 10%. That is what your 70-80% patient will lose even 5 or 10%. But some of the patient will lose even up to 30% or 25% also. So individual vary is very high because it's a very heterogeneous disease. From reducing weight, now we are looking for preserving the bone muscle mass or preserving the muscle mass. That is what we are looking for. That's what Bima have come improve or preserve muscle mass, and we have Kagri, which is potential to preserve the bone muscle. So treatment is not just decreasing the weight, but improving the body composition also. And bone mass should be considered along with muscles also. The conditions which improve the medical obesity treatment, definitely the glucose control, but not only glucose control, other cardiovascular risk factors like hypertension, dyslipidemia, systemic inflammation, even better quality of sleep because less chance of sleep apnea, other mechanical issues like osteoarthritis, the MASH, PCOS, even CKD improvement, heart failure with preserved ejection fraction, with reduced ejection fraction, all other cardiovascular events, CV mortality, all-cause mortality, quality of life, all which we are looking for in a persons with obesity or person with diabetes. And that's what our future treatment will be like that. So from better quality of life to a better function, that is what we are looking for with newer and newer drugs. The history of medicine, the kind of evolution. This is, I think, the first time which we are going to see. Before a few years, we used to treat a person with uh, myocardial infarction. He's already had developed, and now you are treating. Then we started treating a person with getting high risk for developing MI or CKD. These patients we started. And then we started treating the persons who is having diabetes or hypertension, who is at the risk of developing these complications of coronary artery disease or CKD. And now we started treating the people who are going to have diabetes, or because we are going to treat obesity itself, so we can prevent not only these hypertension, diabetes, dyslipidemia, but even the cardiovascular disease or CKD as early as someone becomes obese. So that's what the future of therapy will be there. There are few more molecules which are like in type 2 diabetic patients. Also, we started using, we have done ICODEC clinical trial in India, 2 in my center, FCTORA, 2, they are once in a week. These are the some of the data of these newer insulin. So not only in GLP-1, a lot of new things are coming, but even a lot of new things are coming, even insulin therapy too. They are once in a week, long-acting basal insulin. They also are more efficacious than daily comparator in onward 1 to 5 trials. The FCTORA has also shown a non-inferiority against degludec, which is a ultra long-acting basal insulin. So you can see FCTORA is comparable with degludec as far as HbA1c is concerned in Quint2 trial. Low rates of hypoglycemia. It was not like that. The longer-acting insulin was having more hypoglycemia with a weekly ICODEC, and we had done it with continuous glucose monitoring 2. Hypoglycemia was comparable with Epsitora in Quint trial along with Digludec. So it was almost same whether once in a week or once in a day. Weekly insulin are very efficacious as well as safe as far as their A1C to be reduced and no increase in incidence or duration of hypoglycemia. Combining once in a week insulin is going to come with once in a week GLP-1. We know that once in a day GLP-1 and once in a week, once in a day insulin is already available. But can we combine both? And that's what ICO and SIMA is a combined program. We combine 1, 2, 3, the greater efficacy for A1C reduction because now you have GLP-1 along with basal. So it is going to work for type 2 diabetes like a basal bolus group. Significant weight reduction, no increase in weight by putting them on a insulin therapy. Patients put on good control of A1C, control of fasting, controlling the post meal, and controlling the body weight. All they were there.
Dr.
Weekly.
Sabo, you have 2 minutes, please.
Yes, I'm just ending with weekly semaglutide in type 2 diabetes. Combined trial had shown the safety data also. And in conclusion, innovations are rapidly transforming diabetes management. As I have shown you the data of, and Amit had prepared the slide to show that from newer GLP-1 and the different combinations which are going to be there to not only manage diabetes and weight and also decrease the cardiovascular disease, but even a lot of new things are coming in insulin too. A very personalized approach will be there to offer very outcome. Technology and research there will be a future advancement, and collaboration is key for impactful progression. With this, I thank Emirates Diabetic Endocrine Society as well as Diabetes India for this wonderful opportunity. And thank you on behalf of Amit Gupta to everyone and all the audience. Thank you.
Thank you so much for insightful talk, Dr. Banchi. It's nice to see figures from around the world with high prevalence and then better glycemic control than the conventional treatment for obesity and emerging new treatment for obesity as well. Thank you so much. And now we move on to the second speaker. Before that, please, if you have any questions, write it in the Q&A. We're going to respond to it. Our second speaker, Dr. Mohammed Hassanin. He is the senior consultant in endocrinology and diabetes at Dubai Hospital. He has been there since the year 2014. It is our pleasure to have him in UAE, and it's a gain for the academic activities in the region. He's a senior lecturer and associate director of the postgraduate diabetes education at Cardiff University, chair of the Diabetes and Ramadan International Alliance, co-authored a number of guidelines in the ADA 2005, 2010, in the BMJ in 2010, and in the IDF-DAR diabetes guidelines Ramadan in the year 2016, 2021, and he developed the Wales diabetes guidelines. He has enormous number of publications. At present, he is a professor of medicine at MBRU and Gulf Medical University, examiner of the MRCB UK, recipient of the Diabetes UK in the year 2008-2009, and the European Association of Study of Diabetes, the recipient of the Education Award in the year 2009. Our pleasure to have you, Dr. Mohammed Hassanin, in this webinar. And the title of the talk will be focusing on the CGM in type 2 diabetes. Is it necessity or luxury? The floor is yours.
Thank you very much, Professor Juma. Great pleasure to be with all the friends from UAE as well as from India, and hope everyone is enjoying World Diabetes Day. Let me just fix my slides.
Just enlargement.
Sure. Okay.
Yes, now, thank you.
So I'm going to move to a very practical presentation about CGMS in people with type 2 diabetes, whether this is a necessity or a luxury. And I'm going to start with a very simple case that I'm sure we all see in our clinics. This is a male in his early 50s with type 2 diabetes for 10 years, and he attends the clinic concerned about his control. He's already on triple oral therapy, SGL2, metformin, and glimepiride, and he's also been started recently on glargine, insulin, basal insulin, as he was unable to tolerate a GLP-1. Starting him on insulin improved his HbA1c from 8.3 to 7.8. He does have background retinopathy, no cardiac or renal problems. While his glycemic control improved, he noticed a couple of hypos when he was busy on some of the days. And the question comes in mind, the challenge that we have here, that we see a person, the person is concerned about the hypos. However, the HbA1c is still above target in someone with some diabetes-related complications and organ damage, such as retinopathy. And whether we intensify the insulin with basal bolus or mixed insulin, whether we switch from SU to another class of drugs, whether we stop the insulin altogether or any other option. I don't want you to give me an answer now. I just want you to think of this case scenario as if you're sitting in clinic and what would you do? Now, not achieving good glycemic control is a universal thing. This is data, yes, albeit it's old, but more or less recent data are showing exactly the same. This is an interesting survey when we asked healthcare professionals, about 500 plus from UAE and Kuwait, why are people on insulin not achieving their treatment targets? And many have put the fact that people stop the insulin, lack of support, lack of the experience in self-management. The fear of hypoglycemia is very high, and the occurrence of hypoglycemia itself. So it does look here for something quite interesting. The fear is worse than the actual hypoglycemia itself. So it's kind of like the bark is worse than the bite. Now, when it comes to blood glucose monitoring, to me, this is very important for people with diabetes because it helps them to understand their problem and help them to change their behavior if they need to change it. But for us, it gives us an idea about the current glycemic assessment as well as how to optimize care. The impact of this is metabolic and clinical improvement, safety, quality of life, and certainly economic as well. However, when you think of our barriers as healthcare professionals for intensifying of insulin, we always say that the non-compliance in the patient with regard to monitoring the blood glucose or adjustment, of course, the concern about hypoglycemia, excessive weight gain or already in a person who's overweight, the lack of resources. Many of us are seeing a patient every 10, 15 minutes, and some of us even don't have that luxury, and the lack of time, lack of availability of staff and costs. Of course, the comorbidities and the quality of life for the individuals. Indeed, this is an IDF survey that was published a few years back. And when physicians were asked, which of the following, if either, do you think is the main barrier to insulin intensification for people with type 2 diabetes in your country? Over a third said there is the lack of guidance about insulin intensification, and more importantly, or equally important rather, the lack of patient monitoring to show when insulin intensification is required. So I personally think that blood glucose monitoring can really help us as physicians to overcome the inertia that we often see because of the valuable information that we have can help to change the behavior, help the choice of treatment, and help, of course, in the dose adjustment. We all know about the Joslin Center for Diabetes in Boston. If you would have seen the Joslin Center, you would see this word on the center, the diabetic who knows most lives the longest. So knowledge is really key. And of course, we very frequently need to think out of the box rather than putting a box in our head and thinking within the box. Thinking out of the box sometimes help us. And if you think of CGM in type 2 diabetes, well, if the person is on basal bolus or even on insulin, you will automatically think this is appropriate and let's push for it. Blood glucose monitoring have evolved massively. I don't know if any of you is old enough like me to remember the urine tests that people used to have, the tablets that they used to put, the color coding, and it was all measuring hyperglycemia. It was not measuring hypoglycemia. But we are talking about a tool that's been available for us since the mid-40s. So that is 85 years ago that the first tool for glucose monitoring, not blood glucose monitoring, for glucose monitoring was there. And then, of course, when you see the biggest blood glucose machine that was there initially, and then the development of the CGMS. Any given HbA1c is an average. An average can have little variations, such as in blue, or high variations, such as what you see here in orange or red. So the average, really, the HbA1c give us an idea, but does not tell us how high or how low the person has been throughout the day. These glucose variations are very important, of course, because hypoglycemia is bad, but also hyperglycemia is bad. And indeed, the glucose variability has an impact on the cardiovascular system as well. Now, when we moved to the earlier versions of the continuous glucose monitoring, these were the types of graphs that the patient was seeing as well as us. And it really needed a magician to try to make heads or tails from these difficult graphs to chase every day from day to day and what happened on that particular day. So technology really, I believe, that has been a great tool to bridge the gap between us as healthcare professionals dealing with people with diabetes and the person with diabetes themselves. This roller coaster of blood glucose variability has been made much better with the CGM and the average glucose graphs and that we have. And I'm delighted to share with you some of the studies that we have done in our center. My co-speaker, Amin Abdul Qadir, is one of the co-authors, as well as the whole team from Dubai Hospital, including Fathia, were co-authors in this study. In this particular study, it was focused on people who were fasting. And of course, fasting on its own has its own glucose variability, from pretty low glucose levels at the end of the hours of the fasting to pretty high levels when the feasting starts with the sunset meal, where people indulge in large amount of sugary and fatty types of food. What we wanted in this particular study done in Dubai Hospital, that we wanted to look into what we called optimum care. What was the optimum care? Was providing people with diabetes with patient education, structured patient education, flash glucose monitoring, dose adjustment and treating them with the best available treatment options that were there. And they were treated by experts in the field. And what we saw in this particular data, when we compared the sensor data to before Ramadan to during Ramadan or just after Ramadan, you can clearly see that 60% of our patients were having blood glucose level above target. In target was only 34%. Now, you would know that currently the target for time in range is 70% plus. So clearly, our people with diabetes before Ramadan were having hyperglycemia. And this is important. We did the study on 5 different categories of people with diabetes: cardiovascular disease, gestational diabetes, diabetic nephropathy, type 1 as well as type 2 on insulin. And among all of them, it was clear that we have lots of people with blood glucose variability. So when we look into the data, as I mentioned, pre-Ramadan, as I mentioned, it showed a lot of people above target. And certainly, when I look into an example of one of the patients, which in our study, which took place in 2016, you can clearly see the hyperglycemia during the night, starts in the evening meal, and sustained throughout the night. But during the last fasting hours, you start to see better figures. And indeed, you can even in some days see hypoglycemia. Such a jump from low or normal to pretty high is a cause of concern for many, including, for example, people with diabetic retinopathy. So clearly, if I were to have that graph, with my person with diabetes in front of me, will be able to address the type of food, the nature of the food, the drinks, the treatment, and certainly one would be able to adjust the treatment to try to overcome this sustained hyperglycemia that lasts from 6 p.m. until the following morning. And the early hours of the morning, 8 and 9, you can still see here about 200. So that certainly is someone that you would like to see that graph, share with them the information. And certainly to me, this is at all not a necessity, not a luxury, this is a necessity. I would like to share with you a latest publication that was published just a couple of months ago, published in July, 25th of July, end of July. This was a systematic review and meta-analysis of several randomized controlled trial on CGMs in people not treated with insulin. So type 2 diabetics not treated with insulin. Many of the names of the authors, you would know them: Alice Cheng, Harpit Bajaj, and others, all very familiar to us. And this is the data of the HbA1c. And here is the different types of CGMs, whether the interstitial, whether the real time, or whether the professional CGMs. And clearly, they all show that in people with diabetes, with type 2 diabetes, you can see an improvement in HbA1c that favors the use of CGM. Indeed, when you look into time in range, again, regardless of the type of CGM that is used, the overall favors again the CGM, improving the time in range, and in some of the studies quite significantly. And again, in some of these studies, people were on oral therapy, pure oral therapy, and in some it was oral therapy with some basal insulin as well. So to me, I have no doubt in my mind that CGM for many people with diabetes would help them for understanding this. This is the consensus of the group that wrote the systematic review. They say that it should be considered to increase individual time in range and lower HbA1c, the two parameters that I've clearly shown you of clear benefit of CGM in people with type 2 diabetes, not non-insulin treated. They should be considered to improve patient glucose monitoring satisfaction and to reduce the distress that people with diabetes have, which is something we should not underestimate. The concern about complications, the concern about the number of medication, the hypo and the hyper. And on top of this, we're asking them to prick their finger 3, 4, 5, 7 times a day to be familiar with what's going on with the blood glucose levels. Of course, CGM may be considered as a component for structured diabetes education and lifestyle counseling to optimize behavior change in diet, management, and physical activity. And I will come to that in further depth in a minute. But it's always the question, is it the tool or is it the understanding of how to use the tool? The tool on its own will not be enough. And I see many of my patients coming with their phone to show me the app of their CGM, and they are not engaging with them because perhaps they need more of the structured education to know how they can use that tool. It certainly can be a useful tool to support us as healthcare professionals in making our decision. I just saw a patient in my clinic for pregnancy and diabetes clinic that I do jointly with the obstetrician, a young nurse working shifts and having lows in some parts of, on some days, on basal insulin and metformin. And after discussion, it was very clear with the data that she needs to have a CGM as well as basal bolus insulin to give her the flexibility and the understanding. CGM should be considered, of course, to reduce the events and hospitalization. If we can prevent hypos, if we can prevent the peaks, then we prevent hypoglycemia admission as well as hyperglycemia related problems. Whether we use the interstitial or the real time, that's obviously based on many, many options, including the person preference and, of course, the consideration for costs. Earlier types of CGM showed us this, and this is yet again data from 2016 when we did the study, and we saw this flat line which is not compatible with life. The sensor was saying 40, and that was continuous from 2 a.m. until iftar time or eating time. Of course, that was not correct. And this was not just a single case, but was a number of cases. I'm delighted that the newer sensors, the newer generations of the sensors, we don't have the generation 2, but we know we have the second. But certainly the generation 3 of sensors have better accuracy in the lower. You can clearly see that there is a difference in the accuracy within the normal range versus the lower range. But is much better than the earlier versions, which had a bit of the problem of too many hypoglycemia that were not true hypoglycemia. And that obviously could be a clinical dilemma. Should I break my fast or not? Should I increase my basal insulin if I'm pregnant or not? Should I stop driving or not? So many important issues that would make a person need to make a decision upon. So, ladies and gentlemen, blood glucose monitoring in any shape or form is not a luxury. It's an absolute necessity for both people with diabetes as well as us healthcare professionals. But of course, it needs education and behavior change so that it can help us with all of these options. Education is key, but unfortunately, we focus far too much on the newest drug, the most expensive one, the latest kit, and we forget, as Nelson Mandela mentioned, that education is the most powerful weapon which we can use to change the world, let alone, of course, education for a person with diabetes. I'm delighted that there is improvement into that field. For people with diabetes and Ramadan, we have 2 applications. One of them is dedicated for people with diabetes called the Dar Safa, which is abbreviation for safe fasting, where people would be able to make instructed information about their choice of food, the content of the food, to be able to make a decision. How many people of us addressing today or sitting today in the meeting know that this 2 small pieces of bread would be 33 grams of carbohydrate and a single piece of toast? The difference between the white and the brown is about 2 grams per slice. Not a massive difference, although the patients sometimes think that yes, it is a lot different. If we as healthcare professionals wouldn't know this information, why on earth do we expect the person with diabetes to be such knowledgeable on the different types of food and the carb content, which obviously would affect their glycemic level, whether they're able to adjust it for the meal or not able if they're on tablets. So, ladies and gentlemen, Mr. Chairman, in summary, glucose monitoring technology such as flash glucose monitoring or real-time glucose monitoring or even SMBG is definitely an absolute necessity for all people with diabetes, including people with type 2 diabetes who are not treated with insulin. It will help them to understand their problem, help them to prevent the hyper or the hypoglycemia. The sensor data could be powerful to empower people with diabetes, as well as give us valuable information for better decisions. Of course, we have to provide the structured education for people with diabetes that will make them benefit from the understanding of the problem they have, as well as certainly understand how can they utilize the CGM. It's very simple, which was said by Blonde in 2002. It is not the collection of blood glucose data, but rather the effective use of blood glucose information for making clinical decisions that leads to improvement in diabetes care. And Lord Kelvin said, if you cannot measure it, you cannot improve it. Thank you all, and I look forward to the question and answers.
Thank you so much, Dr. Mohammed Hassanein. Thank you so much for interesting and clear talk. And now we move to our third speakers. Dr. Banchi, could you introduce the third speaker, please? Thank you so much.
So it gives me great pleasure to introduce Dr. S.R. Arvind. Dr. S.R. Arvind is a senior consultant diabetologist from Bangalore. He is currently president of Diabetes India. He is director of Diacon Hospital, Bangalore, a very senior consultant practicing since last 35 years. He has done his DNB medicine. He is a fellow of Royal College from Glasgow and Edinburgh. He is fellow of multiple diabetes society, including our RSSDI. He is also a Diacon Hospital, is an IDF Center of Excellence. He's a course director for PG studies, under him post-graduation for diabetes by Rajiv Gandhi University and RSSDI, that is JNU University, Jaipur. He was past president of RSSDI, has conducted multiple clinical trial of phase 2 and phase 3, more than 150 publications, authored many textbooks. He is a Guinness Book record holder for highest number of foot screening in a one day in 2013. He has got Lifetime Achievement Award from Karnataka RSSDI as well as from Diabetes India. It's great pleasure for me to give this introduction for Dr. Arvind, and I will request now Arvind to give his talk. Thank you.
Thank you. Thank you so very much, Panchi, for this. And thank you, Chairman, and thank you, Emirates Diabetic Association, for having asked me to speak. And we just heard some great talks, and I will quickly now be moving into my talk, which will, again, I think the focus nowadays is going to be more and more on the clinical benefits of weight loss. And we heard Dr. Panchi speak about what's in for store for us in future. And you can see my slides. Banchi, give me a thumbs up if you can see my slides and if you can hear me well. Thank you so very much. So I will start with this first slide, which is, self-explanatory, the kind of benefits that we get when once we have our overweight reduced. And we know we have a lot of mental, mechanical, and the metabolic benefits. But then I will just stick to the benefits of reducing weight, basically on type 2 diabetes and glycemia, and then what happens to the CV risk factors. And for this particular talk, these are some of the references that I have taken. I will not go into the details of many of these studies because some of the nice studies which are ongoing and likely to come out, Dr. Banchi has already covered it. So the topic of discussion is basically on the clinical benefits of weight loss, on diabetes and CV risks. The first important thing that we all have to understand is whatever may be the weight loss, even the modest weight loss, delivers a very, very clear clinical benefits for people with type 2 diabetes and also has benefits on the cardiovascular risk. A 5 to 10% of weight reduction from the baseline yields the metabolic improvements. and we know what these metabolic improvements are. And if you move up, and then if it's about 10 to 15% weight reduction from the baseline, we may actually have a disease modifying effect, and we may also look for remission. So this is a simple slide which was actually shared by Dr. Banshi before. Even a small reduction of 0 to 5% has an impact on hypertension and hyperglycemia. Now, when you move to 5 to 10% of the weight loss, it has a great impact on the lipids and also on the fatty liver. 10 to 15% definitely has effects on MASH and OSA. But coming to glycemia, we know 5 to 10% is what we kind of need to typically lower the HbA1c by roughly 1%. And this, of course, varies with the starting A1C and the diabetes duration. And UKPDS and so many studies in the past have clearly told us what exactly that 1% reduction of HbA1c means in terms of microvascular and macrovascular complications. So important to remember is any amount of weight loss, if it can be 5 to 10%, we can reduce medication. It will reduce microvascular and possibly macrovascular complication, as we know from the previous studies. And definitely it improves the fitness and reduces the medication burden. Many times the hypertensive medications are reduced, anti-diabetic drugs are reduced, the dosage of insulin is reduced or even stopped. And we have seen this in practice. A quick look at the factors affecting the islet cell functions and how do we connect obesity with type 2 diabetes. Well, this is something that has been spoken about. This is something that we discuss in most of the conferences, that the adiposity drives insulin resistance and leads to inflammation and lipotoxicity. And this also increases the hepatic glucose output. What does the weight loss do? Actually, the weight loss can reduce the hepatic and pancreatic fat. It improves insulin sensitivity and, of course, improves the beta cell functions. And these changes can underlie a very rapid improvement in both fasting and the post-meal glucose values. Well, this was a question which was asked to me a couple of days back by one of my students. He asked me a question that I don't have a reference, sir. How much of weight loss can actually reduce cellular inflammation? You know, this is a very interesting question because we know and we talk about increase in the pro-inflammatory cytokines and adipokines. We talk of TNF alpha, IL-2, IL-6, leptin, and so on and so forth, even HSCRP. This is something that we don't measure. This is something that the patient does not feel. Now, how do I know my anti-inflammatory cytokines are actually getting reduced? And it's also know that if you have more of a visceral fat, that matters the most than the overall weight loss. So the more visceral fat you reduce, the more of the pro-inflammatory cytokines reduce. So that means your cardiovascular risk definitely comes down as the cellular inflammation comes down. And we have enough of references for this, but in terms of numbers, if you can measure TNF alpha, IL-6 and HSCRP, we can see measurable reductions. Now, the small changes are noted even with a 5% weight loss. But what is important is if you can have 5 to 10% of sustained weight loss, then there is a greater reduction in the pro-inflammatory cytokine levels noted. That means it has to be sustained for at least 3 to 6 months. So for researchers in this group who are actually listening, it's not actually a bad idea to start measuring TNF alpha, IL-6 and HSCRP and then see what patient of yours is actually getting the benefits apart from the benefits on the blood sugars and benefit on CV risk, etc. Do we actually see cellular inflammation in all our patients with overweight, or is it only in those with high visceral fat? And what happens when once they start losing weight? And this is just a cartoon which talks about the healthy individuals on one side and an obese person and how the obesity actually affects. So if you want to just take some messages back home, the weight loss improves not just the metabolic control. We also know adiposity leads to inflammation and lipotoxicity and insulin resistance, and there is going to be a reduction that we can see. We see a reduction in both liver and pancreatic fat, so we can see a reduction in hepatic glucose output and an improvement in the beta cell function. So weight loss at this point of time, we have enough evidence that it reduces ectopic fat, lowers the insulin resistance, blood pressure, triglycerides, and inflammation. It varies from individual to individual. And if you can have a sustained weight loss, the benefits are anyway going to be better. Now, what about remission? I mean, this is a question that people often ask. At what level of weight reduction do I see a remission? Normally, if you can have about 10 to 15% reduction in your body weight from the baseline, I think that's about the time you can actually expect the remission. And this has been shown in many of the studies, especially after the bariatric surgery. And if you can sustain that weight loss, I think your remission also stays for a longer period of time. What about the CV risk factors? Undoubtedly, we have seen good effects on blood pressure. Even modest reduction in systolic blood pressure occur with modest weight loss. The larger losers produce a large BP fall. When it comes to the lipids, reduction in triglyceride, improvements in HDL are known and common. LDL may fall modestly or remain similar depending on the medications that we have been using. Inflammation and metabolic profile, we just discussed about it. So weight loss reduces the markers of inflammation and improves the metabolic syndrome. Coming to the functional benefits, I mean, this is what I see with the patients. They're extremely happy when once they lose weight, their exercise capacity actually increases. They start feeling good, they start going for walks, they are more flexible, and the sleep apnea comes down, they have better mobility and the quality of life. And all of them are relevant to long-term CV health. So there are a number of benefits that you may not be able to measure, but then the patient himself will tell you or the herself will tell you that she is feeling good and she has started to walk, and that's enough to give them a better CV life. So what about the CV risk and the events? The question that is often asked is, we know the weight loss reliably improves the risk factors in the overall health, but does it reduce the hard CV events? And this depends actually on the degree and the duration of weight loss, the method used, and individual baseline risk. And you need to have more than 15%. In fact, substantial and sustained weight loss after bariatric surgery has shown low rates of major CV events and mortality in some of the observational cohorts at registry studies. At this point of time, yes, I did hear Dr. Banshi's talk, which he was doing on behalf of Dr. Amit Gupta, that with some of the newer drugs, what we are seeing in the clinical trial is very, very encouraging. But at this point of time, impact on hard CV outcomes, there is a mixed evidence. Weight loss is heterogeneous in effect. The benefits depend on the magnitude, durability, and baseline disease duration. Not all interventions that reduce weight reduce MACE, but we are seeing a different picture. And I'm sure coming days will tell us that some of the drugs which reduces 20-25% of the weight loss from the initial, this one has a great effect on MACE. In fact, the outcome depends on the intervention and patient population. Some weight reducing drugs have been very, very encouraging. And then we are just waiting for some of the newer clinical trials to actually come out. But we have learned lessons from bariatric surgery and some of the large observational cohorts, and definitely the CV events and the mortality is reduced when once we have a weight loss of 10 to 15%. And long-term adherence and the weight maintenance are frequently the biggest obstacles. We have too many functions, we have too many meetings, and our food is so good. Many times people do not maintain that weight loss for long periods of time. A quick take-home message: even modest, sustained weight loss markedly improves the glycemic control and the CV risk factors in type 2 diabetes. Greater and durable weight loss raises the chance of remission and larger benefits. Selecting the right combination of lifestyle, pharmacological, and surgical approaches is essential to maximize both metabolic and long-term cardiovascular outcomes. Sustained weight loss is what we need. And for this, you need motivation, you need discipline, and you need long-term adherence. There are no quick fix solutions. And definitely, AI cannot help in fixing that. So we do talk of motivation and we do talk of inspiration for our habits. This is just as a joke. I'm just showing you some of these slides. At 67, I'm going to be 68 very shortly. And then definitely I was overweight a couple of months back, but this is the AI generated picture. I'm not this old. All that I would do was to go sit in a beautiful park and do really nothing. And I just needed the motivation. And the motivation was that if you lose weight, there are good chances that you get some rewards. In fact, Dr. Banshi told me that these are the rewards that I can actually get if I lose weight. So I lost weight. So I was able to go for a walk with good-looking ladies. I could smile, hold their hands, and go for a walk. And when I started exercising and started losing more weight, I got more rewards. I don't advise anybody to do this, but then this is out of a joke that you need motivation, you need rewards. So when we are talking to our patients, when we are talking about education, we need to talk about motivation, we need to talk about the rewards, and each one of us. And this was just shown as just a joke. And thank you so very much for a patient hearing. And I don't want any one of you to take the last two slides very seriously, but that was just to talk about the motivation and the rewards that you're likely to get. And that was Banshi's mistake for making me put up those two slides. Thank you.
Thank you. So thank you, Arvind. It was a wonderful presentation. As we both were talking and Amit's slides and that how much weight reduction can help patients. At the end, we can have the question, Juma. Will it be okay? Can you introduce now Professor Dr. Niveen?
Thank you. I will spare the photos for the wife. Our last speaker, but not least, is Dr. Amin Abdelkader. He's a consultant endocrinologist at Dubai Hospital. He's associate professor of endocrinology at Mohammed bin Rashid University, Dubai. He's a fellow of the Royal College of Physicians of the UK, and he is examiner for the MRCP UK as well. Dr. Amin, he published a number of papers, and especially in the field of diabetes and Ramadan and cardiovascular risk. He's an associate editor as well in the for obesity in Spring Nature Journal. He's a member of the active research group and has published over 90 original articles and abstracts. He is a member of regional international conferences and scientific organizing committee. It's our pleasure to listen to Dr. Amin. And the title of his talk will be, could you go to the title? No, before that. Re-emerging obesity treatment from GLP-1 to dual triple therapy. Floor is yours.
Thank you very much, Professor Juma, for the kind introduction. It's always a pleasure to be among such a high caliber colleagues and panelists. And thank you very much for the hundreds of people who are joining us until this late moment in the evening to mutually share the clinical knowledge and experience. My talk will just complement what my previous colleagues have mentioned on management of obesity, but I'll focus basically on obesity management without concomitant hyperglycemia or diabetes. This is my disclosures. And what I'll be doing in the coming 15 minutes or so is just to try to agree with everyone that obesity is a foundation for the cardiorenal metabolic syndrome, and will go through the obesity medical therapy, the past, the current, and the forecast for the future. Then we will conclude with a couple of slides that will just complement what my previous colleagues have mentioned on the cardiovascular outcomes from obesity management. And similar to as a continuum of the AI generation, sometimes the AI just it throws down what you feel. So I hope by the end of this talk and by the end of this continuum of talks, we all agree that obesity is not only how the outfit looks like and how much the belly looks like. It's not only the appearance of the individual that is obese or not. And it's neither the size or the number that the weighing scale will tell you, or even the advanced one when we do the waist-hip ratio or other sort of more clinical indicators of more advanced harmful obesity. It's actually a disease with a concomitant either associated comorbidities or a probable future adverse accompanying events. And I like this comprehensive definition of obesity. Obesity, in fact, is a chronic, relapsing, multifactorial neurobehavioral disease. And then comes the amount of fat that we have, and then the consequences of having high fat content. So it's a chronic disease, and it's a relapsing disease, multifactorial in occurrence, and it's a neurobehavioral disease. And this is where we target the therapy in most of the cases. The magnitude of the problem, Professor Bansi have mentioned the magnitude of the problem of hyperglycemia and diabetes. Unfortunately, the obesity goes hand in hand with the diabetes prevalence. And this is the global prevalence of overweight and obesity in males and females aged between only 5 to 14 years of age. A total overweight and obesity may account around 50% in males and around 50% in females, 5 to 15 years of age. Going further from 15 to 25 years of age, the steep goes even higher. And if we focus on the area between 1990 and the year 2000, there was a very dramatic steep or high prevalence of obesity in this age group. And unfortunately, the worst is coming when people age more than that, more than 25 years of age. The starting point just 25 years ago or 30 years ago was around 50% overweight and obesity in females, 60% in males, but it's growing and it's expected after 20 years to be somewhere around 80% of the total population worldwide will be having either overweight or obesity. So the magnitude of the problem, in fact, this is the most prevalent disease in the world. This has been alluded to in multiple talks previously, but we all know that obesity doesn't come as one unit. It usually comes with associations, either the cardiovascular metabolic associations or even more drastic malignancy that could be associated with just having simply obesity. And as of now, we know, at least we are sure of almost over 200 obesity-related comorbidities. That's either attributed to having obesity or they come along together. It's not only the obesity, actually, even the overweight, and the overweight here is labeled in the yellow figures. Just having overweight increases the likelihood of being metabolically unhealthy by 60%, 90% higher risk of hypertension, and another 50% for higher risk of hyperlipidemia and diabetes. Just overweight, let alone the diabetes that increases the risk of hypertension by almost 4-fold, 400% increase in risk of hypertension compared to non-obese and non-overweight. And it needs only to have obesity. And this slide is old, but what I need to tell or to extract out of it is just need to have the obesity with no associated risk factor to increase the risk of coronary artery disease by 50% compared to non-obese patients or individuals, to increase the risk of cerebrovascular disease by somewhere around 10 to 15% compared to non-obese, and to increase the risk of heart failure by 100% compared to non-obese individuals. And it needs obesity plus multiple risk factors without established diseases to increase the risk of coronary artery disease by 2.6 folds, almost 200% increment the risk of coronary artery disease, 60% increase in cerebrovascular accident, and 300% higher risk of heart failure just by having obesity and multiple cardiovascular risk factors. So it's a time bomb. We need to tackle the roots, not to wait until the consequences take place. Well, as we all know, the pillars of management of obesity are many. It's starting from nutritional therapy, physical activity, behavioral therapy, pharmacotherapy, and in selected patients, metabolic surgery or bariatric surgery. We'll focus only on pharmacotherapy here. And we've come a very long way over the last 130 years, since the year 1890, where the thyroid extract used to be an indirect way of losing weight. It hasn't ever been labeled as weight reducing agent, but that was probably the very earliest biochemical or chemical component that worked on obesity management. And since then, we've got many options, whether they are oral or injectable options. However, as the time goes, many of them fell off the railway. So all those in red boxes were either revoked, they got the FDA approval, and then the regulatory bodies revoked this approval because of the adverse events, or they did not get the approval in the first place. So we ended up with a couple of options. A couple of them were oral medications, and a couple are injectable, and that was basically the GLP receptor agonist. Given the task today is a GLP receptor agonist, we'll focus mostly on the GLP++. So over the last probably 10 or 15 years, we started having the liraglutide as indication for obesity, then semaglutide, and now tirzepatide, and more to come in future. And those are the mechanistic pathways that those medications may interfere with obesity and cardiometabolic disease. As of now, the GLP receptor agonist and the GLP, GIP have got the FDA approval for obesity, type 2 diabetes, obstructive sleep apnea, cardiovascular disease, muscle D, diabetic kidney disease, and osteoarthritis. Not all of them for both GLP and GLP, GIP, but more or less many of them are for both of them. And many of approvals are awaited, including type 1, other autoimmune diseases, peripheral artery disease, and others. Now the semaglutide got for the peripheral artery disease as well. So if we just got a quick screenshot of the last 60 or 70 years, we remained over almost 40 or 40 plus years having multiple agents, which we can call them the first generation anti-obesity medications, and we hardly reached reduction by 5% of total body weight. This has improved a little bit in the second generation between 2010 and 2020, where we hardly reached the 10% total body weight reduction. And since the year 2020, we started having miracles where we started seeing 20% and over 20% weight reduction using semaglutide and tirzepatide. And the very near future, as my colleagues have alluded to, that in the pipelines, either phase 2 or phase 3 clinical trials, we'll be having either dual combination GLP-1 plus amylin, or GLP-1 plus the semaglutide plus cagrilintide, or the triple agonist, the GLP-1, GIP, and the glucagon component. And here we've moved from the 10% to 20%, and now we are aiming for somewhere around 24% of total body weight. A quarter of the body weight will be vanished using those medications in the very near future. Probably most of us are well acquainted with the earlier studies on obesity, using the earlier GLP-1 receptor agonist. However, the coming one, which has already been alluded to by Professor Bansi, that we have the CagriSema, which we expected to be available by the end of next year for clinical practice. And the point here to allude to or to point to that the cagrilintide by itself reduced around 11%, and the semaglutide reduced by around 16%. And the combination was showing a cumulative effect. It's not only synergism, because with the synergism, we expect 10 to 15% extra, but here is almost 60 or 70% additive effect. So this is opening a completely new era in treating people with obesity, and exactly the same phenomena got by having the triple agonist or triple agents, the 24.2% total body weight reduction with using the retatrutide high dose. And it's important to note that 1 in 4 people managed to shed a third of their body weight. So 1 in 4 people will get more than 30% reduction in total body weight using the high dose of retatrutide. So this is a completely different era than what we used to have in the very near past. And as I just mentioned, it's a mix of synergism and additive effect. So having the GLP, GIP, and the glucagon together left all the cardiorenal metabolic organs with no blank spaces. So wherever there is a blank space here, the GLP and GIP are not covering it, the glucagon will fit in, and vice versa for others without going into details. So that's to say, by having multiple agents, we can tackle different aspects of the pathophysiology of obesity and cardiorenal metabolic syndrome on the long run. And we shouldn't be waiting for long. We're expecting by the end of next year or the year after to have a couple of medications that's currently in phase 2 and 3 clinical trials. The orange dots for the oral forms and the blue dots are for the blue forms. So probably by the end of 2027, we'll be having at least 4 or 5 more agents to deliver a better healthcare for people living with obesity. And the far forecast this is what we are looking for. And this is the pipeline of future anti-obesity medications. Many of them are subcutaneous in light green, and many are oral. Many are the subcutaneous and oral in the dark green, and so on. So we're expecting a tsunami of anti-obesity medications to be available in the coming 10 years or so. This has been also covered, but it was covered from diabetes and obesity point of view. This is just 2 or 3 slides. I'll take you back to the trials, step 1 and step 4, where they assessed the cardiovascular risk factors in people with obesity without a concomitant diabetes. And the blue bars are always the semaglutide arm, and the gray bar for the control arm. And the semaglutide managed to reduce the systolic, diastolic, waist circumference, LDL, triglyceride, and improve the HDL in a nutshell. So using semaglutide in obese patients without diabetes improved the cardiovascular risk factors. Moving forward, this is a cardiovascular outcome trial on the semaglutide in people with established cardiovascular disease, whether they had heart failure at the background or not. The blue line is the semaglutide, and the red line is for the placebo arm. The semaglutide managed to reduce the composite MACE and heart failure endpoints in both people with pre-existing heart failure and non-pre-existing heart failure, and that was statistically significant for both. And it's very important to note that we were not used to have this very early bifurcation for non-hemodynamic mediated mechanisms in cardiovascular protection. But here in the first 3 months, the 2 groups started to deliver different outcomes. This has also taken place. This is a study of randomized controlled trial published recently in Nature, where they randomized people with obesity and CKD without concomitant diabetes. And again, from the very early days, they showed the very clear demarcation between the blue line, which is the semaglutide, which is the placebo arm. And important to note that we always say to our patients that this 0.25 milligrams is almost a placebo dose, that it will just warm up the body to get used to the medication and expect the best as the time goes. But here in the renal paradigm, the things have started from the very early few days. And another point to allude to, the moment we stop these medications, whatever we have achieved is on its way to come back to the baseline. So we have to be very cautious about stopping these medications. So that was the semaglutide, which is a single GLP-1, and the GLP-1, when it's added to GIP agonist, this is data from the SUMMIT trial where they randomized over 700 patients with obesity and without diabetes. Again, the tirzepatide, which is a combination GLP-GIP, showed a favorable cardiovascular outcome. However, here started a bit later. Definitely the two trials, the study population are completely different, but here it's around 6 months when we started having the bifurcation in favor of the tirzepatide compared to placebo arm. And this is the KCCQ, which is the structured way of assessing the heart failure. It showed remarkable improvement in heart failure symptomatology in people on tirzepatide compared to the placebo arm. And this is the very recent meta-analysis published a couple of days ago, where they collected over 280,000 individuals on GLP-1 receptor agonists with obesity and with no diabetes on the background. And almost everything was in favor of the GLP-1 receptor agonist: cerebrovascular, cardiovascular outcomes, mortality, kidney outcomes, mental health outcomes. So they were all statistically significant towards in favor of GLP receptor agonist. And I just need to remind you to watch everyone to watch our steps, that whenever we discontinue the GLP-1 receptor agonist or the combination, all the cardiovascular risk factors start to creep up back to the baseline. So the decision of discontinuation must be backed up with loads of science and justification. Those medications are to be lifelong medications, since we agree that the obesity is a chronic medication, unless contraindicated, of course. And just draw your attention for a document that's worth reading. I will not go into the details, but it's a Nature paper from the European Association for the Study of Obesity, where they personalize the choices of anti-obesity medications based on the underlying the obesity-related comorbidity. So whenever you have this demarcating conditions, then you choose the medication based on that. This is also published a couple of weeks ago, and it's available in the literature in the online. So with that, Mr. Chairman, dear colleagues and friends, please allow me to conclude that obesity is a chronic relapsing disease that needs a long-term continuum of care. Anti-obesity medications, in absence of concomitant disease, diabetes, have shown robust cardiovascular benefits. Loads of anti-obesity medications are on their way to refine obesity care. And we had the first and second generation of anti-obesity medications with just less than 10% total body weight. Currently, we're having medications that reduces almost 23% of the total body weight, and we're wishful and hopeful to have very near future more than 24% total body weight loss to be provided to our beloved patients. And with that, I'd like to thank you very much and concur on obesity is a chronic relapsing multifactorial neurobehavioral disease. Thank you very much.
Thank you so much, Dr. Amin, for clear, interesting talk. Now we're coming to the part which is the Q&A part of it. We're going to spend 5 minutes on that. We have a number of questions. Shall I start, Dr. Sabu?
Yes.
Okay.
So there are a lot of questions, and
Yeah.
Amit, you can join. Dr. Mohammad Asmin is there, Arvind is there, Amin is there. So one is greetings from Chennai, Dr. Aditya. He's asking the role of agents reducing inflammation and novel mechanism. like activators of glucokinase or inhibitors of 11-beta hydroxysteroid dehydrogenase, GPR40 agonist. Anyone want to take it? Dr. Elamin? These are the newer molecules which are glucokinase activator or inhibitors of 11-beta hydroxysteroid dehydrogenase or GPR40 agonist. These are the role of agents in reducing inflammation. These are the future molecules. You want to take any opinion for you?
Yeah, I have little knowledge about these molecules, but they are still in just started the phase 2 clinical trials, and the aim is just to ameliorate the cardiovascular, the inflammatory process related attributed to metabolic disease and obesity. Still they are in phase 2 clinical trials as far as I remember, and still it will take a long way to get the clinical outcomes out of them.
Thank you. Amit, you want to take this? Any update regarding contraindication to GLP agonist, especially for those who have thyroid disease? I think Amit is not there. Amit?
Sir, sorry, can you repeat the question, sir, please?
Is any update regarding the contraindication to GLP antagonists, especially those who have thyroid disease?
So right now, for the GLP, there is no contraindication for any thyroid disease. But the combination with the GLP and GIP, definitely we do ask for the history of any medullary carcinoma of thyroid in the first degree relatives. And if any such history is there, then probably we have to move with some caution. So right now, thyroid disorders are not contraindication for any GLP-1 based therapy as of now.
Does the addition of amylin analog make a difference in this regard?
Right now, sir, I think we have shown the phase 3 trials, the Redefine 1 and the Redefine 2, and we could not see any red flags as of now.
Exactly. So is BIMA available for practice? It is not. Even the phase 2 and phase 3 trial has been shown, but no CV benefit found to be there with BIMA. So I don't know 3B and clinical trial. Further cardiovascular outcome trial is needed for the same. Again, Dr. Aditya is asking, since burden of diabetes is increasing in neonates and children, pancreatic transplantation is limited by organ availability by decreased donor, whether genogenetic sources of islet should be researched. Just a thought. Dr. Mohammed Asnin?
Yeah, say again the question, please, Banshi.
So he's asking regarding the pancreatic transplantation, genogenetic source of islet.
I didn't get the question.
It is an animal source of beta cells to be implanted in the human, xenogenetics.
I'm sorry, I'm having couldn't hear you well, Banshi. So yeah.
Yeah, could I touch on that? This is mostly animal research that has been limited in terms of experiments in human beings, and now with the genetically modified approach, they've been starting on pigs that some of the islet cells could be genetically modified that suit humans, but still in the experimental arms, there is nothing from animal source yet as study to be planted in humans and functioning.
Very true. When the stem cell, Vertex is one company who had already come out with a beta cells, and it is with the Lantidra, which is US FDA approved also, and they are doing phase 3 trial also for replacement for type 1 diabetes too. There is a for Dr. S.R. Arvind. Question is any anti-diabetic medication that maintaining low blood sugar level for longer period without much fluctuation?
I mean, I really don't know. I think it's a very long question.
All GLP-1 analog
GLP-1s are there. And see, most of the anti-diabetic medications, if you're not talking about GLP-1 injectables, etc., like you have your DPP-4s, you have your SGLT2s, etc., who do not cause hypo, and then I'm sure they do maintain good blood sugar. It just depends on at what stage of diabetes we are using and in what type of patients. And see, there are a number of studies, CGM studies based for even DPP-4 inhibitors and SGLT2. So, I mean, it's kind of a vague question, but then I thought there's no one single answer when it comes to which is the ideal anti-diabetic medication to maintain good glycemic control.
Dr. Juma, this is very good, interesting question. The role of metformin when you have the benefits of SGLT2 and GLP in CCAP. Anyone and everyone can take this. Where will be the future for metformin when you have GLP1 and SGLT2 with the benefits which they are giving for cardiovascular in CCAP? To start with, Juma, you talk about it and then everyone can give their comments on the same.
I can volunteer an answer if you wish.
Yes,
Go ahead,
Alice.
please. Yeah, go ahead.
The cost is a very important factor. Tonight we've been discussing the Rolls-Royce of treatment, the GLP-1, the GLP-GIP, and the future triple agonists. How many people in our countries, even in Dubai, are able to afford these drugs for diabetes and indeed for obesity? So certainly for diabetes, all available drugs, not just metformin, all available drugs have an important role. The sequence of choice might change as we're currently preferring these drugs for people with high-risk cardiovascular or renal problems. But nevertheless, when you put someone on GLP-1, it's not as if all problems will be sorted. So I certainly think that all diabetes medication have a very important role to make.
And this drug metformin has been in the market since 1958. And over time, we thought it's going to disappear, but still proving its presence over time. And it has wide use, as you know, and I don't think it will come off soon.
But in some parts of the world, metformin, I mean, the SGLT2 are off patent and some of the older GLP-1 are also off patent. And in 2019, ESC had already given their comment and they have come out with a guideline also with a person with established cardiovascular disease. The first choice, even before starting metformin, SGLT2 can be the first choice, even before starting the patients on metformin.
This is true, but it's the first choice, not necessarily
I know.
the
I'm
only
not
choice.
saying that it will be replaced because it's insulin sensitizer, but with the first choice, you can always change, or with the patients who have metformin is a contraindicated.
In fact, interestingly, in Japan, they don't really fancy too much of metformin, and then there's a set of patients who don't respond to sulfonylureas also in Japan. So it's so heterogeneous sometimes.
In China, Arvind, even they use the first choice is the carbos. Even there is not the metformin. They are the highest selling carbos in the world. So
in fact,
their first
imiglamin
choice
is more than metformin. Imiglamin is used so much in Japan.
Japan also.
They don't believe in metformin. They use imiglamin, and then they don't use sulfonylureas, and they say Japanese don't respond. It's always acarbose and oglibose and other things.
Dr. Aditya is asking on a CGM sensor augmented insulin infusion device to Dr. Mohammad Aslim and to that Amit. CGM sensor augmented insulin infusion.
Of course, that is the beautiful potential for people who can afford it again. And I wish that we can try to provide it for as many. To have something that would immaculate your personal pancreas to sense the blood glucose levels and pump insulin appropriately is the ultimate treatment. Of course, it's of great benefit for people with type 1 as well as with those who have exhausted their pancreas for type 2, but the overall use is still pretty small percentages.
Thank you. Dr. Azim from Karachi is asking for recorded session, but it's already available on this. Yes, Dr. Ji, please.
Let's take the last question because we're running out of time.
Yes, just one more. Dr. Aditya is asking, how do you approach for post-bariatric, postprandial hypoglycemia? Dr. Alamin?
Thank you very much for Dr. Sabu for the question. Actually,
you are the best person to answer this question after your paper.
Thank you, Prof. Yeah, this is an area of my interest. It's a clinical dilemma, actually, for the patient and for the healthcare provider. For the patients, because majority of patients, they don't know about the hypoglycemia exists. So they roam around with lots of complaints. They roam around for healthcare providers for many months, years, and before they reach to a healthcare provider that is aware about the entity of postprandial hypoglycemia and the steps of management. The management is simply either nutritional support or pharmacological intervention. By nutritional support, 70% of patients will equalize this hypoglycemia. And that's to say, just simply to avoid the simple carbohydrates, eat more of complex carbohydrates, more of fibers, more protein, and more fats compared to simple carbohydrates and sugars. So to avoid the white things, that's the flour, the macaroni, the rice, and the sugar. So the white things to be avoided and take more of the brown stuff as vegetables and proteins. With that, simply 70% of patients will have at least less clinically significant hypoglycemia, and they will not necessitate the medications intervention. And why we need to avoid the pharmacological intervention? Because this is a lifelong problem. When we started, we need to continue on it. So as long as we can interfere with it, but just by simple nutritional adjustment, then this will definitely be clinically sound. The pharmacological intervention include acarbose that we were just discussing a while ago. The somatostatin receptor agonists are strongly coming into clinical practice, and because they trigger the somatostatin receptor, inhibiting the surge of insulin overproduction after sugary meal. And this is the pathophysiology of the postprandial hypoglycemia. So acarbose, somatostatin receptor agonist is still in the areas where we don't have this luxury. We can use the calcium channel blockers like the old verapamil and other calcium channel blockers. And despite not being backed up with strong evidence, but the GLP-1 receptor agonists have clinical very favorable outcomes. So many of those interested in obesity medicine, they use the GLP with a very favorable clinical outcomes. We are in the phase of getting the data out of our cohort. So that's the summary of it. Acarbose, somatostatin receptor agonist, calcium channel blockers, plus or minus GLP-1 receptor agonist.
If obesity is disease, will insurance company will cover anti-obesity medicine? That's, I mean, in India, it's OPD basis. We don't have coverage of insurance for outdoor patient department, but what is in UAE situation? Three of you, any of you can answer, and we can close the session.
No coverage in Dubai.
No coverage in Dubai?
No coverage in Dubai.
Okay. Sir, should we close? And Dr. Juma, can you give final
thank
word
you
of
so
thanks?
much. Thank you. Thank you so much. Thank you for our audience. We had a good number of audience, more than we expected. Thank you for being with us until the last minutes. On behalf of the Emirates Diabetes and Endocrine Society and Diabetes India, thanks a lot for our speaker, Dr. Banshu Sabu. He is a moderator and speaker. Dr. Amit Gupta, Dr. Muhammad Hassanin, Dr. Ariband, and Dr. Al-Amin. Thank you so much for remarkable and interesting talks. And just a reminder, this webinar, it is CME accredited. You shall receive your CME certificate within 14 days from today. Please write your name clearly on it. And whoever who missed this webinar, you could catch up with live webinar on the website of the Emirates Diabetes and Endocrine Society or on the YouTube channel. You could, there's a QR code there, you could scan it. Could you go down, please? There are a number of events coming on the way, and almost we have weekly events, if not. There is with Sharjah University, create webinar. It will be on the 20th of November. There is an association as well, the Young Leader Forums, with young consultants well-versed in their field with interesting cases to discuss on topics. The event is coming soon on the 26th of November. Next one. And another session as well with Sharjah University on the 11th of December. You could scan the QR code if you are interested to register now. Another interesting webinar with the American Diabetes Association as a collaboration. And this is 3.5 CME points accredited by the Dubai Health Authority. And of course, the most important event, please keep it in your calendar, block your clinics, and be with us. It is the annual Congress meeting of the Emirates Diabetes Endocrine Society, Congress meeting 2026, going to be on the first week of February, from the 6th to the 8th of February 2026. And it will be held at the Dubai International Convention Exhibition Center. Please pass on the message regarding this big, huge events.
Thank you,
With
Dr.
this, we come to the
And
end.
just to inform everyone that immediately after 1 week, we have on 13th, 14th, 15th at Hyderabad International Convention Center, our
That's
annual
great.
Congress of World Congress of Diabetes and Obesity at Hyderabad. And
That's
we
great.
have invited many of you. We also have, this is hosted by Emirate Diabetic Endocrine Society, this webinar, and you have multiple webinar in next 2 to 3 months. Similarly, we also have almost every alternate week, one webinar with different society of the world, with ESD, with EDA, with International Atherosclerosis Society, with International Hypoglycemia Group. So we will be keep on posting to all our Indian colleagues and all our Indians. Thank you once
Lovely.
again to Emirate Diabetic Endocrine Society and all of you and all the speakers. Good night. Thank you.
Thank
Good
you so
night.
much. Thank you.
Thank you.
Thank you, everyone. Thank you so much.
Thank
Bye-bye.
you.
Bye.
Bye-bye.
Bye.